Okay, well, I think we can go ahead and get started. We're at the hour now. It is my great pleasure to introduce Dr. Modele Ogunniyi. Dr. Ogunniyi is a professor of medicine and master physician in the Division of Cardiology at Emory University and serves as the Associate Medical Director of the Grady Heart Failure Program. After receiving her medical degree from the University of Ibadan, Nigeria, she obtained a Master of Public Health and a certificate in Health Finance and Management from Hopkins University. She also obtained a completed a preventive medicine and public health fellowship at the CDC, residency in internal medicine at Morehouse, and cardiology fellowship at Vanderbilt. She's very active in clinical research, which focuses on examining social determinants of health and eliminating disparities in cardiovascular medicine, particularly in heart failure and hypertension. She also studies diversity in clinical trials and cardiovascular disease in women. As a cardiovascular epidemiologist, her goal is to forge links between preventive medicine, public policy, quality improvement, and scientific research. In addition, as if that's not enough, she is very passionate about mentoring and creating equitable pathways to diversify the workforce in medicine. And along those lines, she's received several awards, a mentoring award, an American Medicine Women's Association Inspire Award, and the 2021 Emory University School of Medicine Excellence in Diversity and Inclusion. Dr. Ogunniyi serves as the principal investigator for several clinical trials and is on the advisory board for the Metro Atlanta Heart Failure Collaborative and the editorial board of clinical cardiology. She's active in several professional organizations and serves on the board for the Association of Black Cardiologists. She is active in the ACC and is a member of the Cardiovascular Disease in Women, Diversity and Inclusion Committees of the ACC and the Anti-Racism Committee of AMWA. She's also a fellow of the ACP, the ACC, and the American Heart Association. She's also the vice president of the Health Awareness Initiative in Africa, which is a nonprofit organization whose mission is to promote healthy lifestyles in African communities. We have served together on an NHLBI initiative for heart failure. In her spare time, she's very active in community outreach, both locally and internationally, and somehow finds time to travel and to try new foods. So please join me in welcoming Dr. Ogunniyi. Thank you.
Thank you so much for the warm welcome, Dr. Pavin, and thank you for being a sponsor and a mentor. And I'm so glad to be here today, just talking to you about something that I'm passionate about, which is equitable cardiovascular care. Here are my disclosures. And over the next 40 minutes or so, I just want to share with you, really to drill home the importance of equitable cardiovascular care for the patients that we see, and also to share with you an example of how our Grady Heart Failure Program, through using a multidisciplinary approach, has been able to achieve equitable outcomes. So I usually like starting with definitions to just make sure that we're all on the same page, and I'll go through a couple of definitions. So what do we mean by inequality? So I want you to focus on this picture. We have two kids under an apple tree. If you look to my left and have your eyes focus on the apple tree. So if you look on the apple tree on the left side, this apple tree has lots of apples. But if you look, and the apples fall naturally to this kid. But look at the kid to my right. There are not enough apples on their side. So because of that, apples are not falling. And this kid is wondering, how do I get access to an apple? So simply put, inequality is unequal access to opportunities. So what is equality? So still the same apple tree. Now, if you look at inequality, right, they don't have ladders. They have to depend on whether they get the apples fall naturally, or whether someone who is a sponsor makes the apple available. But if you look at equality, they're given tools, the same kind of tools. So these kids, despite the fact that the apples are not evenly distributed, these two children are given the same ladder or the same step stool that has the same height. So the tools or the resources are unequally distributed, but they're given an evenly distributed resource or tool. So the same step stool, but notice that this kid on the right still does not have access to the apples. He's still wondering, oh, despite the fact that I've been given a tool, I still can't have access to this opportunity, which in this case is the apple. So what is equity? Equity means that you customize the tools. So though they're unequal opportunities, though you have tools, now with equity, you customize the tools to make sure that everybody has access to the opportunities that are available. So notice that this kid has now been given a taller stool or a taller ladder, and now has access to that apple. So the tools have been customized, and that's a simple definition of what equity is. It addresses both inequality, which is there's unequal access, and the kid now has access, but has a customized tool that makes them available to access this resource. But where we really want to go as a society and as a healthcare system is justice. That is our aspirational goal. I draw your attention to the fact now that if you look at the apple, right, we now have equal resources, equal opportunities. The apples are evenly distributed. And the system, and what justice really means is fixing the system, fixing the environment so that everyone has a right or has equal access to not only the opportunity, but to the tools. And you can see that that has happened in this case. So this is actually an example from tech. Tony Ruth is an expert in addressing imbalance, and in the 2019 report, I think that beautifully lays out what we all experience in a day-to-day environment as we take care of patients, even in our own personal lives, the balance or the balance between equality, equity, and justice. So let's bring it home as it relates to cardiology. What do we really mean when we talk about inequities? What do we mean when we talk about disparities? So health inequities in cardiology are systemic, avoidable, and often unjust societal factors. They include structural practices and racism that create barriers to opportunity and thus result in avoidable adverse health status and outcomes. And when we talk about disparities, it's talking about adverse cardiovascular outcomes or health status that is as a result of this health and inequities. So the health inequities lead to health disparities. And when we talk about equity, remember that slide that talks about equal access or customized access both to the tools and the opportunities. So health equity in cardiology is defined as a human right that allows everyone to achieve the best attainable cardiovascular health and outcome by overcoming all avoidable barriers. And social determinants of health, I'm sure you're familiar with it, but just to put in a definition as it relates to cardiovascular health, are the social, economic, educational, and environmental conditions that influence the cardiovascular health, not only of individuals, but families and communities. So I put this image here, and it doesn't matter. This is a paper. This is the central figure from one of our recent papers that was looking at cardiovascular equity in Black women. But for a moment, I want you to step back, and although this picture depicts a Black woman, it could be anybody, it could be any race, it could be any gender. But to achieve, I put this slide here to show that to achieve health equity, it's a multi-pronged approach. So it involves the healthcare contribution of the healthcare system, professional societies, clinicians, and government agencies, all working together to address the systemic barriers that we all face, the low healthcare workforce diversity, the financial constraints that our patients face, the effects of racism and discrimination. And when you think about Black women who have immigrated to this country, they face the barriers of violence, of xenophobia, of the barriers that come with immigration. And even when they immigrate to this country, there's a part that alcoholic stress plays, trying to adapt to the society, taking on the culture of the society and how that affects health outcomes. But the main message of this slide is that to achieve cardiovascular equity, it requires not only an individual effort, but it requires the effort of all. So why health equity? Why is it so important? Apart from the fact that there is a moral imperative to ensure that everybody has a just and a fair right to equitable cardiovascular health and really health, there is a business case because people are wondering, why should I be worried about health equity? Why should the government, why should the healthcare system be worried about health equity? This is one of the reasons. It costs $135 billion per year. It will result in a $135 billion savings to the health system if health disparities are removed. And as of now, current data shows that $42 billion is the cost of untapped productivity due to health disparities. I mean, this is a lot of zeros. $230 billion projected economic gain if health disparities are eliminated by the year 2050. So just think about, when you think about GDP, when you think about the economic cost of health, if we all make this our attainable goal, making sure that our patients get equitable care, be it our fields, it's a cost saving to the system. It's not something that apart from the fact that it's morally right, it will lead to a lot of productivity. And this slide was shared with me by one of my mentors, Dr. Jennifer Mears. So whether we like it or not, health equity has made its way into the systems. This was recently released by CMS. They're going to require that we as clinicians, as healthcare systems, as hospitals, report what we're doing for health equity. So I just pulled one aspect of it, and this is the introductory slide. They are going to require that hospitals document that health equity is a strategic priority for the healthcare system. And they have a checklist where you will not only just state that, but show how you plan to achieve health equity in terms for different populations, not only by race or ethnicity, but all populations that are underserved. How is the healthcare system making it into their strategic plan, health equity? And under health equity, they're going to collect data. So this domain one, the reporting for this year is going to be due next year. But as we move forward, they're going to require the health systems not only collect data on social determinants of health, but have a plan to address adverse social determinants of health. They're going to require us to analyze the data. And not only that, when we identify deficiencies, what are the processes in place? What are the quality improvements in place to address these disparities and thus lead to health equity? And for domain 5, They're actually requiring that people in the C-suite, people who are in management, how are they engaging with health equity? Are they cognizant of what is going on in the system? What active measures are they making sure that everybody in their health system is on a path towards health equity? So I like this slide because it brings it home for me. I call myself a public health cardiologist, but it really brings it home to me because I see my patient in the context of the environment. So social determinants of health are conditions in the environment where people are born, where they live, where they learn, where they walk, where they play, where they worship and age. And the social determinants of health affect a wide range of health. It affects quality of life, it affects outcomes. And when we talk about social determinants of health, according to Healthy People 2020, these are the main domains we're about. For education, what is the access to education? What is the quality of education? So not only, and for us, the relevant thing is healthcare. Not only is healthcare available, but how are our patients accessing healthcare? What is the quality of healthcare? Economic stability, social and community context, and the neighborhood and built environment where our patients live. And you may be wondering now, what is the impact of health equity? I like this slide put together by the American Hospital Association that really drives home for me the impact of social determinants of health. So this 20% is where we as clinicians spend most of our time. But as a determinant of health, clinical care or healthcare is only responsible for 20% of our outcomes. I'll say it again. 20% of outcomes of our patients or clinical care is only responsible for 20%. And that is where the dollars go. That's where we spend most of our time. But 80% is due to the physical environment, the social environment, the behavioral factors that influence how our patients approach care. Relating this to heart failure, in 2020, there was a scientific statement put out by the American Heart Association. And these are the concluding remarks, which I think are very important. Addressing social determinants of health is very vital to improving health outcomes for patients with heart failure. And in the paper, they go into the detail of what they mean, but they call out adverse social factors such as lack of insurance, food insecurity, lack of funds for medication, disability status, and income inequality. And all this lead to worse heart failure outcomes. And the next part of my slides, I will show how we as a health system in Atlanta have worked to address this. So my first point is that not only should we learn to assess social determinants of health, but we should assess social determinants of health and address social determinants of health. So this is a patient I saw over a year ago. When a patient comes into a system, built into electronic medical records is the assessment of social determinants of health. This is done by the medical assistant or whoever is checking in the patient, has to take the vital signs. They go to this tab and assess social determinants of health. For the purpose of this lecture, I've picked food insecurity. And they ask the patient, within the past 12 months, have you worried that food will run out before you have money to get more? Or within the past 12 months, the food you just bought, it doesn't last and you don't have money to get more. And if this patient answers either sometimes true or often true to one or two of this question, this patient gets automatically triaged to our food pharmacy. The food insecurity, this is the wheel I showed you before. It has populated as red because this patient answered yes to one or more of the questions. And immediately, let me go back and show you that in this EMR, if you click on this link, it actually populates for the clinician the food community resources that are available within the zip code of the patient. So this is independent of the clinician. This is a medical assistant checking in the patient. Because this patient has experienced, states that they have food insecurity, it generates a BPA. So it tells that this patient is eligible for a food and medicine program. The patient gets a flyer. You tell the MA tells the patient, this is before they see the clinician, that they're referring them to the food as medicine prescription program. A smart set opens, and right there, the MA is providing education to the patient. And from here, it triggers an automatic referral to our food pharmacy. I didn't show the steps, but it goes through so many steps. And at the end of that BPA, the patient has a prescription, not handed to the patient, but it goes automatically to our food pharmacy. This food pharmacy is right outside the hospital. In fact, it used to be a McDonald's for several years, but now it's the Jesse Hill market, where once the patient leaves their appointment, it was started with patients who have uncontrolled hypertension and diabetes. Just where they get out, they go to this food pharmacy and receive a supply of fresh food and vegetables for a family of 4. They can come every 2 weeks, up to 3 months. And at the end of 3 months, the prescription has to be renewed. And we're tracking blood pressure, we're tracking hemoglobin A1C, we're tracking engagement with the system. And you may ask, how do we fund it? It's a partnership. Grady provides the staff, they provided the location, but the fresh fruit and vegetables are provided by the Atlanta Community Food Bank. And Open Hand is a non-governmental organization that provides cooking classes. So it's all about like partnership. And it's a very beautiful facility just right outside Grady. And it's open to staff as well. We can go in there and have lunch and everything. But this is an example of taking action. Not only do we assess that adverse social determinants of health, we are addressing it by addressing food insecurity. In fact, patients that come to Grady Hospital are 4 times at risk for food insecurity compared to the general Atlanta market. So that's just an example, the first part of my lecture, showing you how we as a healthcare system can be intentional to address social determinants of health. First, we need to assess it and then address it. And it goes for other things, transportation access. I could give you examples as well. So in the last half of my talk, I'm going to talk about the Grady Heart Failure Program, where we have prioritized delivering equitable and patient-centered care. So for those, I know there's some like former Grady folks in the audience, but for those of you that don't know about Grady, Grady is the main safety net hospital for residents of Atlanta. We have 953 beds, and coming online because of the closure of another hospital is about 130 beds to account for the closure of Atlanta Medical Center. It is staffed by fellows and residents, both from Emory and Morehouse School of Medicine, and we have APPs that are employed by Grady. So to give you an idea of the volume of patients, we see about 700,000 patient visits per year. And when we talk about uncompensated care, almost 400 million in 2020, which included 185 million in charity care. Our Grady Heart Failure Program was established in September 2010. It's a unique and innovative multidisciplinary program with our core focus on achieving health equity and improving quality of care for our patients with heart failure. It's unique in the sense that it's primarily run by APPs in collaboration with cardiologists. So this is kind of a schematic of our multidisciplinary team. We have a group of APPs, 10, and some part-time APPs who primarily run the program. They see the patients in the inpatient and outpatient setting under the supervision or in collaboration with cardiologists from both School of Medicine. We also have a nurse care coordinator who is full-time with the program. We have a full-time pharmacist, and we're constantly assessing, have a registry quality improvement person who makes sure that we're achieving our metrics. We're also part of the AHA Get with the Guideline Registry. So this person helps us to track our data. We have a full-time community health worker, and I'll go into their duties as we go on. So this is one of our multidisciplinary team meetings where we meet together as a group, we do case studies, we review patients, and also it serves as an educational opportunity for the APPs. We have like a accredited ground round series where we have cardiologists and people come to talk about different topics just to make sure that our APPs are up to speed with clinical care. So what do the APPs do? They see patients, like I said, both in the outpatient setting and the inpatient setting, both in the ED as well. They're educating patients, the staff, house staff, and really making sure that our patients, especially patients with heart failure with reduced ejection fraction, get on GDMT and they titrate GDMT. Also built into their workflow is assessing social determinants of health and barriers to care. In the outpatient setting, we have clinics every day except Friday afternoon. We have a discharge clinic where patients who are discharged from the hospital with a primary diagnosis of heart failure are seen within 7 to 14 days of hospital discharge. So that clinic, they're titrating GDMT, they're checking labs, they're connecting them with community services. Also, the patients move on, still in the same setting, to a GDMT titration clinic where they are optimizing medication, managing comorbidities, referring them, because we do not have an advanced heart failure service yet at Grady. So connecting these patients with care and talking about, we have a partnership with palliative care that our APPs were actually equipped with primary palliative care skills so they can have the basic palliative care end-of-life discussions with our patients. And we now have a diuretic clinic where patients can come into the clinic, go to the diuretic clinic, receive IV diuretics, and go home. And then come back the next day, they're seen in clinic just to, as an alternative to readmissions. During COVID, we were able to partner with the mobile integrated health team who actually went out to the homes to draw labs and to give diuretics as well. This is the glue that keeps our program together, the program coordinator. So he or she coordinates the schedule. They do patient calls. So every patient that's discharged with a primary diagnosis of heart failure receives a call within 24 to 48 hours of discharge, just asking simple questions. Did you take your medications home? How are you feeling? Did you weigh yourself today? You have an appointment coming up. Do you need transportation? Do I need to arrange transportation? Just making sure that the needs, the social needs, as well as the medication needs of the patients are met. This person also maintains what we call a quality list that has patients who are at risk for readmission or that has specific characteristics of patients that we need to address to prevent readmission. They make sure they have their discharge appointments, they arrange transportation, and we have a partnership, which I'll talk about, with the mobile integrated health team. This person manages everything. So they're kind of the, if you've been into a healthcare system, it's difficult to navigate the system. You can't get anybody on the phone. We have a dedicated phone number, 404-616-3700, where this person is always there to pick up the phone and talk to patients, as well as serve as a liaison to all our partners. We have a dedicated community health worker. So one of the things we identified was that there were so many barriers to health, to healthcare. Patients were going home without their medications. There were patients who were eligible for insurance who didn't know how to apply or didn't have the resources. There's so many resources in the community in Atlanta that patients were not aware of. So it's the job of this community health worker to address those concerns and connect the patients to these resources. So The Grady Heart Failure Program really initially started as an inpatient program, but now we have a clinic which was established a year later, where we provide coordinated, comprehensive heart failure care. The 4 pillars we focus on are: we optimize GDMT, we educate our patients, and we try to troubleshoot the process and the access to care, because it's such a difficult thing for our patients, and we address social determinants of health. This is not a primary heart failure clinic, so we make sure that our patients are connected to cardiology, that they have a medical home, they have a primary care, they have a general cardiologist who's taking care of them. So in kind of just to give you an idea, and I picked 2021, just to kind of a little bit minimize the impact of COVID, because typically before COVID, we had probably like 4,500 to 5,000 inpatient consults. Here you can see some of the impact of COVID. We have a CDU in the ER where our APPs they're constantly there. The heart failure clinic, like I mentioned earlier, they're 9 half-day clinics, and we also have satellite clinics outside of Grady, the neighborhood centers where we see patients. So how have we been able to do this, or what are the components that we really focus on in addition to medical care? So these are the core components of our program that really focus on prioritizing equitable cardiovascular care. So everybody that comes to Grady and is discharged with a primary diagnosis of heart failure receives a 30-day supply of their heart failure medications prior to discharge. It's delivered either to their bedside, or if they were to go to the discharge lounge, they will receive their 30-day supply. And all these components we identify here was because of a baseline, a focus group study that we did earlier on in 2010 to determine the main reasons why our readmission rate was so high, like 25% when we started in 2010. So we identified that addressing these components will ensure that our patients, one, receive quality and timely care, as well as receive equitable care. So they receive this 30-day supply of medications. Like I mentioned earlier, many patients qualify for some form of financial assistance, but they don't know. So we partnered with the financial division, and patients were able to get this. And one thing about Grady, because Grady is in Fulton, residents of Fulton and DeKalb County actually can come and receive care at zero or lower cost based on their financial, or something they used to call the Grady card, but based on where they live, they can actually get care at Grady. One thing that was lacking was connection to community resources. So we have a full-time dedicated community health worker. Transportation is another social determinant of health that was really a barrier for our patients. So we have rideshare support. Initially, we had a grant that supported our efforts to bring patients to the hospital. So this is the job of the community health worker, calling the patient the day before, making sure they have transportation to and fro the clinic. That's part of something that we do. We also have patients who can come out because they're primary caregivers, they have disability issues. We have a partnership with the mobile integrated health team to go out to the house to see those patients who are at high risk, not all patients, but high risk for heart failure readmission. We also partnered to provide medically tailored meals post-discharge. Other services that really have the patient at the center: telemonitoring. Every patient with heart failure at least once gets free weighing scales, pill boxes, and blood pressure monitors. And like I said, anybody who has ever tried to call a hospital, you can never get anybody on the phone. But having that dedicated number, 404-616-3700, and you can get someone to speak to, has really, really revolutionized the way we care for patients. We have a heart failure survival guide. I'll show you an example, developed at 3rd to 4th grade level, mostly pictorial. And these are the criteria for patients who we do telemonitoring, patients who are at risk for readmission. And it's a low bar, really, greater than 1 admission in the past 6 months. We have a dedicated teams, and these are some of the social factors that our patients that we consider. Not only will they have had just more than 1 admission, but if they have any of this, they qualify for remote patient monitoring. And that's set up before they leave the hospital. So this is the Grady Heart Failure Survival Guide, mostly pictorial. It has the phone number. It has things that empower patients to manage their heart failure. It has the symptoms. It has, like, it's a whole kind of booklet that patients look forward and come to the clinic with it. They're like, I've written my blood pressure. It kind of serves as a form of empowerment to our patients. I mentioned our partnership with Mobile Integrated Health, which was really helpful during the time of COVID. You know, patients, they could go out to the house. The patients that we serve really thrive on relationships. So we looked at about 600 visits that we did within that month of COVID. Only 3 patients said, don't come into my house because of COVID. They wanted people to come in to talk with them, you know, and that really helped us during the time of COVID. They could draw labs, could bring it back to the lab. We could titrate medications during the time during COVID, but still our relationship, that team usually has an APP and an EMT, and they go to the home. So what are some of the tools that we've used? We've really used electronic medical record to improve the quality of care. We have like a chronic disease registry. We have my panel metrics that really shows how well a provider is doing. Are they titrating medication? Are they controlling blood pressure? And that's really helped us a lot. Also embedded in our electronic medical records, a care management tool. This is not limited to heart failure, but it collects data, social determinants of health data. But for heart failure, we were able to customize our own tool to look at social determinants of health, to look at quality of heart failure indicators. And of course, because heart failure is really a big money loser or driver for the health system, our health system invested in an artificial intelligence model to identify those who are at high risk for readmission and target interventions to them. So this is an example of the chronic disease registry based on patients who have had encounter at Grady, and my panel metrics really shows this. Disclaimer, this is not mine, but you can see how well this clinician is doing with blood pressure control for someone who has HFrEF. But I think that as we take care of our patients with heart failure, determine accountability, showing people how well they're doing with achieving metrics, because everybody thinks, oh, I'm doing well, my patients are on maximal therapy. But really, when you have objective data, it drives change. This is what I mentioned, that we have a specific tool. Remember that to address social determinants of health, you have to access social determinants of health. So the community health worker completes this, not the clinician. It's there, and they can always update it when patients come to their visits, because believe it or not, like I mentioned before, this really drives outcomes. This is an example of the artificial intelligence, so using real-time data from the electronic medical records to kind of prioritize patients who are at high risk for readmission. And this is an example of the output from the tool. So do we track what we do? Yes. We track what we do because we want to know whether we do better. When we started the program, our readmission rate was about 25%. And really where we see the impact of our program is really in our heart failure specific readmission rates, because as you know, we know that hospital, although it's put out as a metric, we know that readmission rates are really not the metric we all should be focusing on to look at quality of care. But unfortunately, that's what payers are looking at, that's what health systems are looking at. So we track so many things that are important to and this is just like a snapshot from a previous year of what we track, some of the metrics that we track. So how well are we doing? We can do all this good work, but do we really have an evaluation tool or an evaluation system to show that we're doing well? So in 2018, CDC put out a call about looking at programs that really prioritize health equity. And we got selected as one of the programs. And they spent a year evaluating our processes, interviewing clinicians, patients. And what was really beneficial to us was that they did a cost effectiveness analysis. These barriers they identified were the same barriers that we identified from our focus groups and surveys in 2010, but they were able to give us quantity to some of the heart failure patients they interviewed. But this was the most important thing to our health system, because I always get asked this question whenever I present this data: how do you fund your program? Initially, we started by receiving a grant, a community grant that funded some of the social determinants of health work we did. But with this data, that we're able to show to our health system that a net saving of almost $900,000, averting 348 heart failure admissions per year. This led our health system to now build our team from 1 APP to 10 APPs and some part-time APPs. So we're able to, the system cared about, which all health systems do, cared about heart failure readmissions. And we're able to show them that by focusing on health equity, the core components, by taking care, optimizing GDMT, and really addressing social determinants of health, for 300 and almost 350 annual averted readmissions, there was a net saving of almost 900,000 to the health system. When you look at like the program cost versus the savings, and I think that this is what has really helped our health system to invest in our heart failure program. The other data they provided to us is that they were able to show by their analysis that by addressing social determinants of health, social economic barriers to care, our program was able to reduce readmission rate, and you can see the numbers here. Also, because we participate in the Get With the Guideline, AHA Get With the Guideline registry, some of the metrics we track is when our patients receive phone calls, when they come back to clinic, and our program meets and exceeds the goals that have been set. So you can find, and I'm happy to share this link, you can find details of this evaluation, one-year evaluation online. And there's a PDF where they go into really all the core components that I've briefly described here. So as we think about putting everything together, as we think about heart failure care, and before I go to this slide, I will say that future plans for our heart failure program is to have an advanced heart failure transplant cardiologist who can help us, because that's where we struggle. The patients, the 5 to 8% of patients who are early stage D patients who need advanced heart failure therapy. We don't have LVAD therapy at Grady. We don't have heart transplant. But how do we, as general, I'm not trained in advanced heart failure, but how do we get these patients to the next stage of care? You know, because they usually, some of our patients usually, as you can see, have a lot of barriers that usually affect their eligibility. So our health system is investing their plans in the near future to have an advanced heart failure transplant trained cardiologist, not only to make that connection, but also work with the APPs and increase the knowledge of managing these critically ill patients, work in the CCU and all of that. But as we think about heart failure care, this is a perspective that I wrote with a friend of mine, Melvin Eccles, about having another approach, thinking about the multidisciplinary approach to heart failure care. So when you think about heart failure in terms of stage A, pre-heart failure, you know, stage A, stage B, stage C, stage D, what is the role for a general cardiologist with heart failure interest for APPs? I think that we have a role in walking through all the stages, and as you can see, highlighted here, you know, kind of at risk for heart failure, managing the risk factors, counseling, you know, focusing really on prevention. And when you go to the pre-heart failure stage, thinking about preventive cardiovascular disease, there's a role for focusing on women and other underrepresented minorities, really managing risk factors. And when you think about the symptomatic patient, you know, I think there's a role for the multidisciplinary team. There's a role for cardiac rehabilitation. And because there's so many, the burden of heart failure is so huge, we all need to work together. So this is our group. We wrote, was published in the American College of Cardiology magazine, where we talk about how some of the stuff I talked about today. CDC gave us some recommendations, and this was really huge in helping our health system. They talked about doing systematic health equity training for the staff, and for the health system, this was huge, to continue to fund the community health worker position. As part of this, we are constantly thinking about how do we address social determinants of health. We have a huge population of patients with heart failure experiencing homelessness. So we got a $100,000 grant from AEH, which is the organization that represents Safety Net Hospital. And we really focused on developing a community intervention to target our patients experiencing homelessness. We had our community health worker go out to shelters with an iPad where the nurse practitioner was able to talk to them, deliver care. We provide transportation access. We connected them to the food market, just things to make sure that we are really reaching out to deal with other populations. Our program has been recognized both by American Essential Hospitals as well as the American Heart Association. We've achieved the highest level of recognition for the work that we do. So as a roundup, I want to leave you with some key take-home points. You know, we need to really develop an understanding of the impact of social determinants of health. It's no longer a buzzword, but something that if we're going to provide quality care, not only for heart failure, but for all our patients, we got to integrate the assessment and also addressing the social determinant of health into our clinical care. But gone are the days where clinicians have to do everything. We need a multidisciplinary team that consists of community health workers, care coordinators, care navigators, who will help us. They're skilled at addressing these things. So it's a multidisciplinary approach to ensure that that 80% of outcomes that's determined by those negative factors are addressed by people who are skilled. Of course, we need to, research is always needed. We all need to bring this as a research agenda. So we already talked about this. Funding is needed. We need that team, and we need to make sure we're addressing social determinants of health. So I'll leave you with this quote: to achieve health equity for all, we must not only assess social determinants of health, but we must also address social determinants of health. And this is our team. Thank you for your time.
Thank you so much, Dr. Ogunniyi, for that wonderful presentation. As you know, I've been trying to get you here for a long time to share this really impactful work. I think, you know, it's important for us to see this because sometimes we get frustrated treating populations that are high risk and under-resourced, and we give up. But I think you've beautifully demonstrated that with tailored investment of resources that don't appear to be above and beyond what we would normally do. You can be successful and in fact save money for hospital systems. So thank you for that. Any questions for Dr. Ogunniyi? Yes, I agree.
Thank you for an amazing talk and the just inspiring, sweet. Sorry. One of the things that we can do here is maybe additional investment. No money if they stay cost. Almost seems like stomach. Will be working a profit. How would you get that rate to that rate?
Thank you for the question, Dr. Eagle. I think it was a struggle in the beginning. I can tell you that when we first of all started, we had one APP, and we had to write a grant of probably $25,000 to $50,000, not $25,000. And we picked the low-hanging fruit. So we didn't address all these core components at once. So the low-hanging, by what I mean by low-hanging fruit was we were able to partner with pharmacy to pick a select group of patients who the bar was higher, who were at risk for readmission, and we're able to give them a 30-day supply of their medications. And it was not until we had CDC come to spend a year with us and to show that we were saving them money. And I think that, I don't know about here, but at Grady, the way the system works, that we have the Emory and Morehouse employed clinicians, but we also have APPs. So these APPs are seeing patients in collaboration with care, and they're billing. So money is really coming to the system as well. So I think that that has, although we're showing cost savings, I think that we have been able, I think the health system has been able to sustain the program because, one, they get the recognition, two, they see that their readmission is really a big thing for Grady. And I think because they've seen that benefit, they have supported us so far. They're not making money, but they're somehow invested that we're bringing cost savings to the system. Yes.
One of the slides that I think I was really surprised at how people are able to such a huge number of patients truly they can't reach the pharmacy, and you can get access to long medications that you can provide them. We really see steps getting up with the hospital. But for me, just getting to understand how do you develop that building and how you're able to sustain it, because I think it's such a
So I'll step back a bit and describe how Grady is funded. So Grady is funded by, we're in Fulton County, but we're funded by the Fulton County and the CAB Authority. So residents of that county can come to Grady and receive their medications for a zero copay or lower cost. And working with the pharmacy was able, I guess the one thing that we're able to show that it was costing the hospital more to have a readmission than to provide this medication. And remember that most of the medications for heart failure, even if you go to Walmart, maybe they're like $3. So it was more cost effective or cost savings for them to provide that 30-day of medication to make sure the patient came back to the clinic within 7 to 14 days to get their refill, right? Because they only give them 30 days, than to have a readmission that the patient could be in the hospital for. I mean, a length of stay for heart failure is like 5 to 7 days because our patients have multiple comorbidities. So I think that showing that, I didn't show that data, but showing that cost effectiveness, that was cost savings to the health system, provide that 30-day of beta blocker, maybe an ACE, you know. And then Grady also qualifies for, you may ask, how do we get medications like the ARNIs or SGLT2 inhibitors? We have a special, and I'm forgetting what that status is now, 304B status, where we can get medications such as tafamidis and Entresto at the same $0 or copay for our patients within the health system. So I think while this might be peculiar to Grady just because of that safety net status where we have access to medications that ordinarily will cost. And our payer mix at Grady is probably a third Medicare, a third Medicaid, and private insurance, probably maybe one fifth, and like 30% or 25% are uninsured. So that uninsured population, if they live within Fulton and DeKalb County, can get their medication for little or no cost. I hope I answered the question.
All right. Yes.
Thanks for a really amazing and inspiring talk. One of the things that I was most struck by what you achieved at Grady is how coordinated and sort of interconnected and comprehensive your program is, with just many different social determinants of health at the same time. And I think frequently a challenge is, you know, a lot of well-known individuals have quality improvement initiatives throughout hospitals that are independent of one another. And it can be challenging as patients and as care providers to know what's available to our patients. So how did you build that integrated kind of approach to our patients at Grady?
Yeah, and to add to that, the one research we didn't mention is that you need a physician champion.
Yes.
So,
Yes.
yeah.
So I think at the beginning, all this started because that if we didn't address this problem, we were not going to move forward. So they brought everybody together into the room. So there were administrators, there were pharmacists, social work, everybody was there in that room. And then we as physician champions were charged to get the data. So initially to find out what were the main reasons why patients used to come into the hospital. And although it seems as if this is a beautiful program, I can tell you I can present the war side of it, you know, the challenges, the multiple talks, the talks with pharmacy, with, your patient is insured, your patient can't come, we're losing, things like that. But I think that we have taken the approach of building a collaboration, calling in people, multiple meetings, going to primary care meetings, meeting with social workers. And most of the work, I give credit to our APPs. They are constantly, they'll come, when we have our meetings, for example, I'll tell you about sleep apnea. Most of our patients had sleep apnea and couldn't afford the study. So couldn't afford to come and have a sleep study. So we sat with the pulmonary and the department and said, how can we get our patients, we came up with ways to get our patients screened, and they were like, if they can come up with some amount of money, we will find ways to get them the study as well as the CPAP machine, not for everybody, but for a select group. So it takes collaboration, it takes multiple meetings, it takes everybody putting their ego aside and putting the patient at the center of it. There are so many challenges, but I think that over time, we've been with the patient at the center, which is it takes a special person to work at Grady. So I think that just because at the core of their being, most people are dedicated to getting the patient better, we've been able to develop a collaboration that has helped most of our patients, but it hasn't been easy.
We have time for one more question.
That was just inspiring as somebody who's trained in empathy and behavior through Grady. Patients come in telling you they have a history of high blood, low blood, and bad blood, and you're supposed to know what each of those means. It really takes a pretty special person to work there, and this is just amazing. I had a few questions about how you assess social determinants of health. How long does that assessment add? How much effort does an MA need to put in to get that? And also, in your categories, you showed that if somebody says for food insecurity, if they have some issues sometimes or often, it sets off an alert. What if somebody refuses to answer that question? Does that set off any kind of alert for you too?
No. So if the MA doesn't complete that assessment or the patient says no, then they're not enrolled in the program. Initially, like I said, when the program started, it was limited to patients who had uncontrolled hypertension or uncontrolled diabetes. Now they're rolling out to cardiology because we have patients who have that as well. And the second, how much time does it add? Probably about 5 minutes. When the MA, you have been at Grady Clinic, right? The patient spends time in the waiting room even before they get into the clinic. So after the vital signs are taken, when the MA is doing the med reconciliation, they can quickly check and it goes quickly through. And by the time they're leaving, where they go out, where the McDonald's was, they can just go right into the pharmacy. Now, the challenges we have to that is that when they have to come back, we need to think, and I think I was talking about this with Dr. Hummel today, that when the patients, it's easy when they live in the clinic to go and get it, right? But to come back and to re-enroll in the program, those are things that we're thinking about. How do we address those barriers that we have?
Okay, well, thank you so much. I know there are many questions, so, and you have a meeting right after, but feel free to ask a couple questions after we're being kicked out. Thank you so much.
Thank
for
you.
coming. We
Thank
really
you.
appreciate it.
Thank you so much. Thank you.